In this lesson, we will be talking about the accelerated junctional rhythm. In our last lesson, we talked about the escape rhythm, the junctional escape rhythm, and that its normal intrinsic rate is 40 to 60. That is consistent with the AV node driving the beat of the heart, sending electricity both up the atrium and down the ventricles. In accelerated, all we're simply doing is increasing the speed to a rate of 60 to 100. This is the third of 4 rhythms that we'll be covering in this section. And looking at the accelerated arrhythmia, you can see that it is coming at a much more regular frequency than the escape junctional, the junctional escape. Now this is not a 6-second strip, so I would have to do my calculation. Let's just see, 300, 150, 175. We're at about 70 beats per minute with this rhythm. And what you should notice is there's an inverted P wave right before that QRS, and that PR interval is less than 0.12. So in this particular rhythm strip, we do have a P wave that's inverted, and then we have our QRS and our T. Comparing this to normal sinus rhythm, we can see that they look almost the same. They're fairly similar. They both have a regular P wave. They both have a regular QRS. The rates will be between 60 and 100. The PR interval is one of the key characteristics to look for. It's extremely short. And then the rest of that will follow normal. So is this normal sinus rhythm? I don't know. Let's do our analysis. Let's just come back here for a second and look at these P waves. You see how we have this flat isoelectric line, nice round and upright, and then it goes down into a quick dive, straight down up to QRS. This isn't so much as a quick dive. This is a inverted P wave right here. Okay, so the rhythm R to R will be regular. Your P to P will be regular if you can see them. Rate will be between 60 and 100 beats per minute, which is why this one can be really often overlooked for normal sinus rhythm. P wave inverted, buried in the QRS, or absent, can come after the QRS as well. That PR interval, this is the second distinguishing feature, less than 0.12. It's the same for all the junctionals, but the key thing between junctional escape and junctional accelerated junctional is the heart rate. And that's why accelerated junctional is more challenging, because it looks so much like normal sinus rhythm. And of course, the rest of this will follow suit. Now, if you think this is normal sinus rhythm, you really need to consider if it's a positive deflection, like maybe this is the P wave right here. A lot of people have asked me, well, can't this be a P wave? It's the duration in which this is taking that is making this, to me, look like an inverted P. But there is another thing that I can share with you to help you, and that requires the 12-lead ECG. Now, I don't have the 12-lead for this strip, but you would look for those same changes to appear in leads 2, which is what we've looked at, to also show up in lead 3 and an augmented vector foot. These are also known as inferior leads, and so that PR interval should look the same. The P wave should look the same in all of those 3 leads. That will help you determine if it is a normal sinus or a junctional. Causes, this is no different. We've talked about this before, but digoxin toxicity is one of the most common causes for this. MI, cardiac history, potassium changes, electrolytes, disease, anything like surgical that's causing inflammation around the heart and its electrical conduction system. Rheumatic heart disease makes the list. No surprise, it's what we just talked about in the last section as well. Now, the treatment is going to be underlying conditions. Here's the thing, because this is a normal heart rate of 60 to 100 beats per minute, the thing that's missing is atrial kick. The atria are not filling as they would in normal sinus rhythm, so we may have a smaller cardiac output than normal. Most patients will be asymptomatic with this. In some cases, they will require treatment because of the cardiac output deficiency. So again, correct that underlying cause. Look to see if this is a side effect of their medication. Look to do their lab work. Look to do any other investigative diagnostic tests that are necessary to try to figure out what is causing this particular rhythm. That's it. That's a short one. We're going to go into junctional tachycardia next.